When I started in healthcare, I went to a management course and they were talking about healthcare finance. In the course, they started talking about productive versus non-productive hours. Productive hours, by what they said, was anything that was time at the patient's bedside. Non-productive time, of course, was anything away from the patient's bedside. Then they got to a point and they started talking about education. And she says it this way. She says, education is non-productive time that should be limited or eliminated if at all possible. And I took a moment and, wow, this bothered me. I mean, it's personal to me. My mother's disabled. She spent too much time on the other side of healthcare. And to me, education is the way that we actually can improve to take care of our patients. But you need to understand healthcare finance, because educators, or facilitators of learning, as we're going to start calling them, are actually in healthcare finance. Because in the mindset that education is a non-productive time that should be limited or eliminated if all possible, is why our budgets get cut. It's why we can't get resources, and it's why we can't do the good initiatives we want to do. So to shift that and move away from healthcare and a mindset that is just a cost, we need to look at learning a different way. I'm going to propose 5 principles for learning in healthcare. Number 1 is it's all about the patient. The patient comes first. The patient is the reason we're there, and it should be the reason why we do the education. Now, if you buy into that, that means that the patient is at the core of everything, and the educator and the student is not. That means if the student passes the course but it doesn't help the patient, it was a waste of time. It also means if you as an educator want to talk about your best topic you love, and it doesn't have an outcome, it's a waste of time. I love education just for education purposes, but in the healthcare finance world, we can't do that. We are spending the patient's money. We are then in a volume to value world. The patient is actually the one who gets to determine should the money be spent on something. And they want to spend the money on initiatives that help them. So the patient needs to be the core of everything we do. And the patient sees us as a team, not as individuals. And that's important. When a patient is sick, they don't go and say, hey, I want to go see just a nurse or a doc. They want to get better. So that's why they come to us. So we need to start training together in order for our patients to get better. That doesn't mean we do a training initiative every once in a while or a teamwork initiative. It means we need to make interdisciplinary education part of everything we do, because that's how we work. The second principle is that education does not equal learning. Just because you sat your butt in the seat does not mean you learned a thing. And that's hard because we are used to tracking student hours and time and how many students came through the doors and how long did they spend and what did we do in that time. But that is time that people don't want to spend money for. That's time the patient doesn't want to spend money for. So just because you sat your butt in a seat does not mean you learned a thing. We're just checking boxes. And if we're doing education just to check a box, we shouldn't do it. I'll often ask people, are you doing this to check a box or to actually change an outcome? If you're doing change an outcome, come to me. If you're doing check a box, don't waste my time. The third principle is that learning equals changed outcomes. We know we've learned when we actually changed an outcome at the patient's bedside. And many hospitals use a balanced scorecard. That might be clinical quality, work life, finance, and customer service. It doesn't matter what the scorecard is, but whatever the organization is measuring for the patient is what we in education should be measuring. Now, the hard part in learning is how do you translate something from the classroom to practice? Well, to do that, we have to think about things in a different light. We need to start thinking about things in 3 areas: the learner or the individual, their experience, and their environment. We need to change all 3. What happens is when we have an education initiative that fails, it's because we missed one of the 3. In healthcare, we love to just put a policy out and think it's going to change things. It doesn't. Or we like to just do this wild education. My favorite's hand washing. Many organizations have up to 8 hours of education on hand washing. Now, I don't know about you, but my mother taught me to wash my hands. This is not a hard topic. What we need to do is look at this in a little different lens. If you think adding more knowledge is going to change hand washing, you're wrong. It's not like people say, I don't know why I need to wash my hands. We have to shift the way the individual thinks, their mental model. We need to shift it in practice, and the environment needs to support it. Now, I could teach hand washing pretty easily, and I do this in simulation. If a caregiver goes and touches a patient without washing their hands, boom, patient dies right then and there. Well, that's actually the experience that the student is lacking, that they can't get that shift in their mental model. So we need to do it a different way. In simulation, you can set a rule in your center that if you don't wash your hands and you touch a simulator, a patient dies and the scenario is going to restart. It teaches a valuable lesson. You can't do that in real life. Now, in real life, I like watching hand washing. I watched this gentleman. He was an EVS or janitor worker who was out cleaning rooms. And he walked into the rooms with his gloves on, washed his hands with his gloves on, cleaned the whole room, washed his hands with his gloves on, went in the next room, washed his hands with gloves on, and I watched him wash in, wash out, but he never took his gloves off. And I had to understand this as the education geek in me. And here's what happened. I asked him the question. He said it this way. He said, look, you all told me we were having a tough financial time and to conserve supplies. So that's what I've been doing. Because if I use different gloves every time, I'll use an entire box. And the gloves are just there to protect me from the patient. So I just wash them. And he's right. We taught him to wash in, wash out, and we taught him to conserve supplies. What happened was his environment was fighting. The other part of the environment for hand washing is what happens if the sinks are broken? Or maybe if you go to the alcohol dispenser and it hurts. In one group I worked with, they saw that 10% of the caregivers had a reaction from the dispenser. Well, 10% means 10% of people are going, that's going to hurt if I wash my hands. We need to shift the environment. Changing the environment is not enough either. We need to change the way the individual thinks. In one hospital, we used a model that also is using an influencer. 3 steps: wash in, wash out, 200% accountability, and say thank you. Real simple. 200% accountability says, I wash my hands, and I've got your back to make sure you wash your hands. And if you don't wash your hands, I say wash your hands, and you go over, wash your hands, and say thank you. In that hospital, went from the mid-60s to the mid-90s and sustained it. Children's Hospital do it one better. The patients in Children's Hospital, kids, can actually be engaged in a game. The game is catch the healthcare provider not washing their hands. One hospital did this, and if they didn't wash their hands, the student got a star. Well, it wasn't really student time, it was the patient. And what would happen was the person who didn't wash their hands had to go to the principal's office, the principal's office being the president, and sit in front and explain why were they too good to wash their hands. You got to see this. When kids see a provider come through the door and they don't wash their hands, or they almost don't, they're like, oh, and then they wash their hands like, oh, man. It's a great game, great accountability. Ultimately, we need to shift the way people think about it. And adding more knowledge is not going to get you the outcome. Knowledge is the education model. Learning says, I've got to do what I need to do in the learner, the experience, and the environment to change the outcome. If you're working with Six Sigma and Lean, that does great tools for the environment, but actual learning can help with the individual, their experience. The 4th principle is a little controversial. The 4th principle says that learning is an expertise of its own that should be used and consulted by subject matter experts. What's implied in there is that subject matter experts should be at the bedside. See, there's a problem. The longer you've been away from the bedside, the harder it is for you to be credible and for you to teach. John Maxwell says it this way, that if you're teaching it and not doing it, you're teaching history. We need to think about this differently. Learning itself is its own expertise, and content experts need to respect that, and we as learning experts need to respect the content experts. We need to work together if we're going to have high-value learning that changes outcomes. The 5th principle, and last, is that everybody's in learning. In healthcare, we've got a constant state of change. We need to think about this differently and think about everybody being both a learner and a facilitator of learning their entire career. You as a nurse or a physician are constantly teaching. It may be other providers, it may be patients. We need to build skills in how to facilitate learning and how to learn specifically from our experiences. If we do that and do all 5 principles, we'll have a high learning organization. So to sum it up, the 5 principles are rather simple. Number one, it's about the patient, and our patient sees as a team, not as individuals. Number two, education does not equal learning. Number three, learning equals changed outcomes, and changing the outcomes takes a change in the learner, the experience, and the environment. Number four is learning is an expertise of its own that should be consulted by content experts. And number five is everyone is in learning. Together, those five principles will make a high learning organization in healthcare, which also is a high reliability organization.